Karen, you're seeing a lot more IBD patients in clinic. That's an individual that has a diagnosis of Crohn's or ulcerative colitis. Tell me more about what you're seeing as a common pattern, how this is managed by the NHS, and what can be done from a functional medicine perspective.
Really interesting, because I think we discussed it before, but there's a lot of similarity with just IBS, as we say. So I'm seeing a lot of people in clinic who have, bloating, frequent or infrequent bowel movements.
So it could go to one extreme or the other.
Yeah. Sort of IBS umbrella symptoms, maybe some blood in the stool, and that's led them to further investigation. So where the differentiation comes in the NHS is we look at a marker of inflammation in the body known as calprotectin. And when the number gets above sort of 120, I think is the cutoff, we then say this is now progressed to an inflammatory bowel disease. There is a progression, and you don't suddenly wake up and you're 120. There's usually a downward slope in that direction. So stool testing is so important because we could track calprotectin when it's a bit lower, put some interventions in place, and it can be really effective.
And calprotectin is used as a constant marker of surveillance on the NHS for these IBD patients, isn't it? But what you're suggesting from stool testing is actually not just measuring the calprotectin, but maybe looking at a wider scope of the picture over bowel health that could be negatively affecting that inflammatory response that's going on within the colon. So what might else you be looking for in that stool test that maybe the patients, they've already got their diagnosis, their calprotectin went up, they had symptoms, they rightly went to their GP, they got referred for a colonoscopy, they've done a biopsy, they've got a diagnosis, they've come to you. What else might you be looking for that might give you information to help that client on trying to regain control over their inflammatory bowel?
Exactly. Well, lots of clients will come to me and they've already had an endoscopy or a colonoscopy, and they've had a stool test on the NHS, which usually just calprotectin. So a functional or comprehensive stool test that we offer, we're looking at markers of digestion, so protein, fat, and carbohydrate breakdown. We're also looking from a structural perspective, is there any issue with the barrier here? Now I think there's some fact that if you were to lay out all of your colon with all the little bumps and crevices, it will cover the surface area of a football pitch. It's a huge, vast area. So if we imagine all of that, we're looking at, are these surfaces now a little bit eroded? Is that actually, do you have reduced surface area for absorption? We can tell that on the stool test, and we can also look at improving barrier function. And then we look at the microbiome. So it's like a party, and you want to have people there on the guest list. So they're the foundation, the people that you want there. And then if you've got party crashes, can be fun for a little bit, but then it can get a little bit out of control and it's no longer your party anymore. And these bacteria that we have that are overgrown, the unwanted guests, they can create symptoms of their own. So you may get increased pain with partial bowel movement, for example, or you may have, like we're talking about, blood in the stool, or stomach cramps, or bloating, or various degrees of severity. And then we're looking really at sort of dealing with that microbiome, so improving the host bacteria, the people who want to be there at the party, and getting the bouncer to kick out the people who shouldn't be there.
I like it. Yeah. So actually really understanding that whole ecosystem within the gut gives you an idea over how well one can regulate their immune system, regulate inflammation, find out a bit more about what's going on with digestion and absorption, can actually mean, rather than just focusing on the diagnosis, which is what happens in kind of IBD clinics, isn't it? You've got a diagnosis of Crohn's. Here, let's give you a anti-TNF treatment. And we're not knocking those treatments. They can work. They can really work. But we know they don't work for all patients. Mm-hmm. And most of these treatments generally work for a finite period of time. And then we might have to go on to the next and then the next. And of course, they have implications.
Yeah, that's the thing, isn't it? There's known side effects of these drugs. So often you then have to take another drug to deal with the side effect, and before you know
Yeah.
it, 10 drugs.
Yeah. So what you're saying is, if a client has a diagnosis of IBD, they've been down the NHS route, you keep staying on the NHS pathway, but come and see you. Let's find out what's going on with the party in the guts, who's in there that wasn't invited to come in, i.e. bacteria, parasites, other pathogens, and see what levels of invited parties are there for the taking.
Are the right bacteria there?
I think that's a really lovely way for everybody to look at it. That makes sense in everybody's brain. And I think it also, anybody who's listening that has an IBD, it gives you something to focus on that's about making progress in the right direction. Thank you so much, Karen. That's a really great insight into the link between bowel testing of that ecosystem and healthy working immune system from within the gut. Thank you to all of our listeners, and please do feel free to share, because you might not be affected by an IBD, but you might know somebody who is. Take care, Karen, and thank you to everybody.